Good morning. Thank you, Chris, and thank you for kicking the Oreos out of the way so that I can walk around. Well, in 1990, nearly 2/3 of the children of Vietnam under the age of 5 were starving. A program where supplemental food was given to families had been interrupted, and the health of that country's children was declining very rapidly. A team of volunteers from Save the Children went to Vietnam to see if they could help. In one village, the volunteers quickly noticed that the children actually were healthy and well-nourished. They wondered, how could that possibly be? Were the caregivers of these children doing something different? All the villagers thought they were preparing meals exactly the same way. Initially, there appeared to be nothing unique about the families with well-nourished children. It appeared children received the same amount of food, and there's no difference in the cooking techniques that were used. So why were some kids malnourished and others not? When the volunteers watched the villagers prepare the meals, they noticed two small differences between households of well-nourished children and the others. In the households of well-nourished children, caregivers frequently washed their hands. Those same households also fed their kids different kinds of foods. Specifically, the well-nourished children had tiny shrimp and crabs that were gathered from the rice paddies, and they had greens from sweet potato plants that was added to their food. So you see, in Vietnam, at that time, most households followed two traditions. First, that was good, wasn't it? Shrimp and crabs were reserved for working adults to maintain their strength and their health. Second, greens from sweet potato plants were stigmatized, and they were a low-class food, and they weren't commonly added to their meals. So hand washing and the addition of small amounts of protein and vitamins were the two practices the volunteers observed in well-nourished children. That's it. That's it. Two small practices that deviated from the norms of the culture, but they yielded life-saving results. Two very simple practices, actually, that made a monumental difference. So social innovation scientists, they call this positive deviance. This approach focuses on those who demonstrate exceptional performance despite facing the same constraints as others. Volunteers from Save the Children wanted to spread this throughout the country, but they knew it wouldn't be easy. The volunteers knew that if they came in from outside the country and they said, we have to tell the local villagers what to do, how to care for the children, it wouldn't fly. They knew the change had to come from within the village. So the volunteers recruited those positive deviant caregivers. They had them prepare meals with those whose children were malnourished in order to share those positive practices. So side by side, the villagers changed their circumstances. Ultimately, what started in one village spread to 150 villages, impacting 2.2 million people. Yes, it's excellent. You're right. Decades later, these practices have normalized. They've become part of their routine. The children remain well-nourished to this day, all because of good hand washing and the sharing of shellfish and greens. Now, I've mentioned positive deviance a couple times. It's based on a principle that says it is easier to act your way into a new way of thinking than it is to think your way into a new way of acting. Now, I know that's a mouthful and a big thought to take in. So let me repeat it for you just one more time. It's easier to act your way into a new way of thinking than it is to think your way into a new way of acting. Deviant practices are a mechanism that allow us to act our way into a new way of thinking. They jar us, they shake us up, they push us in a new direction. They do this simply by making us question our usual practices to allow us to arrive at a better result. So let me ask you a question. How can we, nurses, how can we act our way into a new way of thinking and eventually a new way of being? It got me to thinking, how would I act if I were truly in charge of my practice the way I want to be in charge of my practice? What would it look like if we designed the EMR around the way we worked? Yeah. What if we were asked, as nurses working at the bedside, to find solutions to our staffing challenges? Right? And what if we pushed back on regulations that don't make sense? It would be a little bit like nirvana, don't you think? Well, actually, you and me making our optimal contribution would be spectacular. And it is kind of like a vision of nirvana, but sometimes I can catch a glimpse of it. Let me tell you what I mean. But I have a confession to make before I go much further. I spend most of my days at work reading and interpreting regulations. Now, that might lead you to believe that I like regulations. I do not. Like most of you, I feel stifled, I feel shackled by all the volumes of regulations that are imposed on our work. So why do I go to work every day and focus on regulations? Why? Well, I do it because I love to find ways for us to flourish in our practice despite all the regulations. You see, in my job, I assist healthcare practitioners to focus first on how they wish to care for the patient, and then we look at how can we comply with the multiple requirements. Now, don't worry, I haven't crossed to the dark side of regulations. So let me share an example with you of how I act to challenge conventional thinking on a daily basis. Now, I'm sure many of you have gotten a daily physician's order for those nonviolent med-surg restraints. You know the ones where we put the soft wrist restraints on those confused patients to keep them from extubating themselves or pulling out their lines. Well, we had that same practice. We had that same practice in the hospitals of my health system. And I was told by everyone I asked said, bedside nurses, nursing directors, quality analysts, we do this because CMS says it has to be done. Now, I'll give you a little insight to my personality. I'm the type of person who likes to challenge. I like to challenge the status quo. I don't like being told that I must do something without being given the rationale. Thank you for that. So I used my voice to find out if it was really true that I had to have a daily order to use the restraints. I was methodical, I was purposeful, and I'm telling you, I must have read those CMS regulations 10 times. And then I opened up the Joint Commission manual and I read those standards 10 more. You know what? I couldn't find it written anywhere. Nowhere. So still being very purposeful, still thinking really critically about my approach, I again used my voice, and this time I sent an email to CMS and to Joint Commission. And I asked them, is this really a requirement? Do we really have to get a daily order? Guess what? It's not. It's not a requirement. And here's what CMS said, and I quote, "There is no requirement for a daily renewal order for nonviolent self-destructive restraints. This is up to the organization to define per policy." I felt like a kid in a candy store, thought maybe I just won the Powerball. So I immediately called all my friends in shared governance and said, look, I shared the good news, this is great, look what we have the opportunity to do. So we worked to change our restraint policy and we eliminated the statement requiring a daily renewal order for nonviolent restraints. Yeah. We've also changed our CPOE order and our EMR documentation. We removed the daily alert to get the order renewed every day. No more reminders popping up on the computer while you're trying to chart, telling physicians and nurses to get an order. But most importantly, we changed our practice. Now, this is just a small win, just a small one. But what if we could have dozens of these small victories at hospitals, at healthcare systems across the country? What if we could apply them to the whole of nursing practice? In 2016, the Institute of Healthcare Improvement, the IHI, facilitated a week-long initiative called Breaking the Rules for Better Care. Senior leaders at 40 organizations across the United States asked patients, families, and staff if you could break or change one rule in the service of better care experience for patients or staff, what would it be and why? Nurses, our healthcare colleagues, and patients across the country identified 500 rules. 500 rules they'd like to break to improve patient care. Although there were 500 rules, we can kind of put them into three categories. They found they fell into three general categories. First, the first category was rules that need clarity. These are rules that aren't really rules, but myths or habits. Second, there are rules that need to be redesigned, administrative rules that we have the power to change. And finally, the third category is rules that need advocacy because they are in place due to regulations and policies beyond organizational control. So let me give you a few examples that I think will resonate with you to kind of give you an idea of these three categories. An organization wanted to change the visitation policy, restricting children in the ICU. This recommendation came about because of a young mother who was in the ICU critically ill after delivering her baby. Her prognosis was guarded, her spirits were really low. The staff feared that she may not live to meet her newborn child, and her husband asked to have the infant brought into the mother to see her mother. But the hospital did not allow patients or visitors under the age of 11 or under the age of 12 to visit patients in the ICU. Now, I know you all pretty well, and I know you know what happened next. Yeah? Huh? That nursing staff broke the rule. Yeah. They broke the rule and they brought that baby into the mother. The reunion was happy, the mother's spirits improved, her motivation to live improved. It was a long, hard road. We have those sometimes in the ICU. But the young mother survived and she went home to her husband and her infant child. This story ended happily, but the nurses thought, what would happen to other critically ill patients who wanted to see their children or their grandchildren? So this was a rule that needed to be redesigned, and the organization, led by strong nursing leadership, changed that policy. Another hospital wanted to get rid of their policy that inpatient pharmacy could not send inhalers home with patients being discharged. How many of you have run into this situation, right? The patient's prescribed a new inhaler while they're hospitalized, yet you are not allowed to send it home with the patient. You have to toss it at discharge. The patient's inconvenienced, has to purchase another inhaler at a retail pharmacy, and let's hope they have the means to get to the retail pharmacy. So this hospital contacted their state's board of pharmacy, and they learned this was a myth, a misinterpretation of the regulation. The inpatient pharmacist could relabel the patient's inhaler with required elements, provide instructions at discharge, and send it home with the patient. This redesigned practice eliminated inconvenience to the patient, it reduced waste, and it potentially saved the hospital, and most importantly, the patient, a potential readmission. And the last example I want to give you of rules is several of you know this rule, and several hospitals identified that CMS rule that they wanted to break, the rule that patients must have a 3-day inpatient stay before post-acute skilled nursing care, expenses are covered. Yes. So the IHI convened a group of hospital leaders, CMS officers, and they discussed the challenges this rule created for hospitals, for patients, and for the whole healthcare system. With a collective voice and a collaborative spirit, the possibility now exists that this rule can be changed in the future. So at times it feels like these outside forces are driving our practice. But here's what Break the Rules Initiative found. They found that in reality, only 1/4 of the rules getting in the way of patient care were imposed by an outside regulatory agency. That means 75% of the rules were the result of misinterpretation of the rules or were self-imposed, like requiring a daily order for nonviolent restraints. Now, what that means to me, the person that likes to challenge, this means 75% of the rules are within our control. These examples show the strength that we have when we use our voice to change and improve the lives of our patients. And they impact our work environment. When we use our collective voice and the strength we have as nurses, we can invent our future, not become victims of it. Our voice and our strength give us power. right? The power we need to change this profession we love so very much. Now, these empowering stories are small victories, actually, but they have inspired our theme for this year. Our voice, our strength. Now, I believe these words, and I believe the power behind these words shows us how to act our way into a new way of thinking. Remember, the families of Vietnam eradicated malnutrition because Save the Children noticed small changes one village made, but it was the community using their voice and their strength who made the change and drove the change. It was the team of those ICU nurses that changed the visitation policy in the name of better patient care. Doesn't most lasting change almost always come from within our community or our hospital or our unit? It is not driven by outside experts. But if those of us inside that hospital or unit don't do it, change is still going to occur, and sometimes at great risk. What is imposed on us by others often produces outcomes that are not optimal. Reinventing our future cannot be left to outside experts or a tedious study coming from a think tank. It must come from the efforts of nurses everywhere who are dedicated to the care and the delivery to our patients and improvement of the lives of our patients. It must come from you and me. It must come from us. It must come from a community of exceptional nurses. It is going to result from the power of our voice, the power of our strength. Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. I love those inspiring words. They come from Marianne Williamson, and they remind me that fear and power both dwell within us. So let's be courageous. Reinvent our future. We can create the workplaces we want and need when we use our voice. Let's confidently boldly step into our strength. Will you join me? Let me see your very best power pose, and let me hear it. Will you join me? Strength makes you powerful beyond measure. Thank you so much.